My name is Dr Bob Ryder from Birmingham in the United Kingdom, and I'm presenting data on the relationship between canagliflozin treatment response and the duration of diabetes. The data is from the Association of British Clinical Diabetologists, or ABCD, nationwide canagliflozin audit. These are my disclosures. The ABCD nationwide audit programme assesses the safety and efficacy of new diabetes therapies and devices as they come into real clinical use from phase 3 clinical trials. Clinicians all over the United Kingdom submit data into a secure online database. The data is anonymised and then analysed. The canagliflozin audit was launched in the beginning of 2016, and so far the findings have been that by the first return to clinic at a median of 14 weeks after starting canagliflozin, the hemoglobin A1C has fallen by 0.8% from 9.1% to 8.3%. The mean weight fall is 206 kilograms, and there are also falls in systolic blood pressure and alanine aminotransferase. The patients in our audit tend to be more poorly controlled and heavier than the patients in the clinical trials. We also found that between the first return to clinic and second return to clinic, the hemoglobin A1C, weight, systolic blood pressure and alanine aminotransferase all continue to fall significantly. And we found similar falls in hemoglobin A1C when canagliflozin was added to one other oral hypoglycemic agent, 2 other agents or 3 other agents, though the fall was slightly less when it was added to patients on insulin. The rationale behind the current analysis: in the ABCD nationwide liraglutide audit, we found that the impact of liraglutide on hemoglobin A1C was less with increasing duration of diabetes. Thinking about the way canagliflozin works as an SGLT2 inhibitor, by increasing glycosuria and improving glycemic control in that way, the action being independent of beta cell function, one would expect that the impact would be not depending on how long the patient has had diabetes. By December 2018, we'd accumulated data on 972 canagliflozin treated patients, of whom there were 604 with a baseline hemoglobin A1C greater than 7% and a follow-up hemoglobin A1C. 434 of these patients had duration of diabetes data, and these were the ones that were analysed. Patients were stratified according to their diabetes duration. We had 3 groups: 0 to 5 years, 6 to 10 years and greater than 10 years. Changes in hemoglobin A1C were compared across groups using analysis of variance. These are the baseline characteristics of the patient. Diabetes median duration 6 years, baseline hemoglobin A1C 9.2% and baseline BMI 33.7. And this was the main finding, that basically the hemoglobin A1C at first return to clinic at a median of 4.1 months after starting canagliflozin, there was no difference between the different groups with regard to the fall in hemoglobin A1C, as you can see on this slide. If we compare this finding with the finding from the ABCD nationwide liraglutide audit, which I mentioned earlier, there's a clearly reducing impact on hemoglobin A1C as we move through the different durations of diabetes. Of interest, when we did the same analysis in the ABCD dapagliflozin audit, the same result was found. So we found no relationship between duration of diabetes and fall in hemoglobin A1C when canagliflozin was in real clinical use in the UK, and it should be considered a comparably effective in all patients of all durations. This contrasts with the nationwide liraglutide audit and is in keeping with the differing modes of action of liraglutide and canagliflozin.